So a very good evening everyone. Hope I am audible and visible to everyone. A very good evening everyone. This is Dr. Ankit Goel. So we'll be starting. Good evening Ria. Good evening Yogesh. A very good evening everyone. So we'll be discussing some important MCQs of psychiatry today in this session. So a very good evening everyone. First of all, I'm sure all of us have heard this news that NExT is deferred, and let's hope whenever it comes, and if it comes, we have given adequate time to the examinee batches for the preparation. But again, a very important point which I want to stress upon is that clinical and integrated questions have been previously in your recent exams have been there in good quantity. So today in this session we are going to talk about some important clinical questions, integrated questions in psychiatry. Good evening Dr. Benedict, good evening Dr. Sarfaraz. So a very good evening everyone. So this session which we are going to discuss today is going to be helpful to all the students who are preparing for the upcoming exams, that is the FMGE exam, which is just around the corner, then the NEET PG and even the INI-CET and the NExT exam whenever it comes. Now, one very important point I would like to stress in this session is I'm going to talk about some important updates which have happened in the recent time, so that all of us are prepared of those updates. And I'll talk about some new drugs which have been approved by the FDA for certain conditions. So I'll utilize this session in discussing those points as well. So let us begin. Good evening your stats. Good evening everyone. So let us start with the first question today. The question is, a 21-year-old male is brought to the psychiatry clinic by her girlfriend. She states that he has been very obsessive about the boss and often complains about things that are hard to believe. So upon inquiring, the patient states that his boss has secret chips installed in him and that my boss keeps a track of my activities, which he is saying, even when I am not in my office. The previous day he ran too fast and fell across the road because his boss' car was following him. So according to him, his boss was following him. He is going to report his boss to the police. So he is totally convinced that his boss is following him and is tracking him. So the question is, let's try to understand. The question is, which of the following disorders you do not have such episodes? Very good. So the correct answer is very good. So let's try to understand. First of all, tell me what is the symptom which we are seeing in the patient that he believes. So very good. So all of you, yes, Yashwant, Simhu, Somita, Ruxana, Dr. Priyanka, yes, very good. All of you have marked it correct. Very good. So first, can you tell me what is the symptom we are dealing with here? So what is the symptom we are dealing with? Very good. Yes, Mithu Kumar, very good. Dr. Priyanka, yes. So what we are dealing here in the question is, we are talking about delusion, which we know under thought it is a disorder of content. It's a false fixed firm belief or idea which is held with extraordinary conviction. Very good. So here what is the patient having? The patient is having a false belief, fixed belief. So it is a delusion. Can anybody tell me which delusion are we talking about in this? So sometimes they ask you to identify the delusion, like in the case in INI-CET last exam, they gave you a symptom and they asked you which is the delusion. Can you identify the delusion? Very good. Yes, all of you are correct. So the delusion here is delusion of reference. The delusion here is delusion of reference. So here the person believes that people are talking about him or they are spying on him. So again, let us try to understand these symptoms. Let us try to understand these options. So of course option B, yes, we have depression with psychotic symptoms, we will have delusions or hallucination. Even in schizophrenia, very good. Yes, yes, Ria, Mithu, it is, yes, it is delusion of reference. So of course option B and C, again it's very clear that yes, psychotic symptom, delusion is a psychotic symptom, and we can find here. Now, do we find delusions in dementia also? Now, when we'll discuss dementia, of course we know in dementia there are cognitive impairment, but in dementia we also discuss neuropsychiatric symptoms. So there are neuropsychiatric symptoms also, and delusions, hallucinations, these can also occur in dementia. So the correct answer is D, conversion disorder. So in conversion disorder we do not get delusions or hallucination like psychotic symptoms. So what is conversion disorder? It's a neurotic disorder. What is the new name of conversion disorder? Again, just few points about conversion disorder, very important, recently has been asked in various exams. Conversion disorder, it is functional neurological symptom disorder. This is a new name of conversion disorder in DSM 5. So basically person has neurological symptoms which do not have a organic basis. So these are functional neurological symptom disorder. Can anybody tell me any important phenomena seen with conversion disorder? Any important phenomena seen with conversion disorder? Again, this is an important MCQ. So I'll try to discuss certain important MCQs along with the question. Any important phenomena recently asked also seen with conversion disorder? A person is having some serious symptoms. For example, the person is not able to see, but the person is very careless about these serious symptoms. So what is this phenomena which is seen in conversion disorder? This was recently asked also, very important. It is known as la bella indifference. La bella indifference, that is careless attitude towards serious symptom. Again, this is important term associated with conversion disorder. So the right answer here is conversion disorder. Let's come, so before this also, what is the most common delusion which we see in psychiatric disorder? It is delusion of persecution. Delusion of persecution is the most common delusion, right? So a recently asked question in INI-CET was that a person says that I have no brain, I don't have any brain, so what is the point of eating anything? And the person was having depression. So the question was asked, which of the following delusion is seen in that patient? So the answer of that question was, it was delusion of nihilism. The answer was delusion of nihilism. So again, this was recently asked question. We know that what is Cotard syndrome? So there was a confusion in that question. Cotard syndrome, we know what is Cotard syndrome? A person having depression along with delusion of nihilism. So that was also given in the option, but the question was, which of the following delusion was seen in the question in the patient? So please remember, such questions sometimes, you know, they play with the words. Please try to see what they are asking. Sometimes the last line becomes very, very important. Very good. So let's come to the second question. Again, a very important prospective new question. You know, such questions may come in your exam, you know, a future question, such questions may come. So the question is, a 65-year-old male is brought to you by his wife and has noted a personality change in the patient since 3 months. The patient is being interviewed, and when you are interviewing the patient, he answers every question with the same 3 words. So which symptom best fits in this patient's behavior? What is the answer? What is the correct answer? Hello, Anup, hello. Yes, very good. So yes, Chandani, Yashwant, Anshika, very good. The answer is very good. So the person is repeating same words again and again. What is this phenomena? Very good. It is perseveration. Very good. It is perseveration. Please remember, circumstantiality is when the person gives unnecessary trivial information, but ultimately he reaches the goal. We already discussed what is delusion. Very good. Yes. Our time. Yes. Arjun, Anup, very good. Amit, Gangaram Chaudhary, Mohammed, Shahabi, Abdullah, Rajat, Dr. N. Kumar, very good. All of you have mentioned it correct. Flight of ideas is when the thoughts flow very fast and the goal is not reached and they are connected by either chance, so there is a chance connection, or they may be connected by clang association. So you should also know points about these phenomena. Let's talk about what is perseveration. So perseveration is an abnormality of flow of thought, under which it is abnormality of continuity of thought. What is perseveration? Please remember, just remember 3 P's. Perseveration is when a thought persists beyond the point of relevance. So one thought is repeating again and again. So patient is saying something again and again, although it has lost the relevance. So as in this case, patient is repeating same thing again and again. Very good. Now can anybody tell me where will you find perseveration? It is seen in which condition? So can anybody tell me what are the conditions, 2 important conditions? I want you to tell me in which you may find perseveration. And also then let's try to make a diagnosis out of it also, that what diagnosis the person may be having. So let's try to go one notch higher, and also we'll try to see the diagnosis. Okay. So first tell me, very good, yes, first tell me what are the 2 important conditions in which you may find Yes. So perseveration can be found in one, yes. Perseveration, flight of ideas, yes, you can find it in mania, very good. Perseveration seen in one is organic mental disorders, organic mental disorders, and another important condition is schizophrenia, very good. So let's try to understand. So these are the two important conditions in which you may find perseveration: organic mental disorder and schizophrenia. Very good. Yes, Riya, it is schizophrenia. Very good. Now can we go back to the question and let's try to see. So we have made this answer that yes, it is perseveration. Can we now make the diagnosis of this patient? Can anybody tell me what could be the diagnosis of this patient? So we have learned that there are two conditions in which you can get perseveration. Can you tell me what could be the diagnosis in this case? Very good. Yes, schizophrenia is one condition. Yes, superstar Krishna Kumar, very good. Anup, Riya, very good. So now can you tell me what is the diagnosis here in this case? So we have two options. One is schizophrenia and the other is organic mental disorder. So can you tell me? Very good. Yes, Dr. Benedict. Yes, it is organic mental disorder, as it is showing that there is some personality change which has occurred. Again, personality change may occur because of involvement of frontal lobe. There is no symptom suggesting of schizophrenia in this case. So see, it's an elderly person having personality changes. It is suggesting us that maybe the person is having organic mental disorder. So sometimes again with certain clues you may be asked questions like this. I hope this is clear to everyone. So this is the next question. Now, so this again this type of question may be asked, that a psychiatrist asks the patient what is your name, and the patient says my name is Mukesh, and it is correct. Now the psychiatrist says what do you do? The person still replies that my name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. So this is how the question may also be put in front of you, that you are asking certain questions to the patient, but the patient is replying with the same answer. So this thought is now persisting beyond the point of relevance. It is irrelevant in the later questions. So this is perseveration. Very good. So this is perseveration. Now let me ask you one more scenario. You ask a patient, what is your name? The patient replies, what is your name? What do you do? The patient says, what do you do? Where do you live? The patient says, where do you live? So now can you identify what is this phenomena? Can anybody tell me what is this phenomena? Whatever you are asking, the patient is replying with the same answer. So what is this phenomena? Can anybody tell me what phenomena is this? Very good. Yes, Amit. Yes, Afsar. Riya, Arsenal. Very good. That phenomena is echolalia. Very good. One of the catatonic symptoms. Very good. Echo is to repeat. Lalia means word. So person is repeating, mimicking the examiner's speech. Very good. Achan Khan. Very good. Anshika, very good. So yes, it is one of the catatonic symptoms. So one should know how to differentiate, because sometimes these two may be given in the same option. Very good. Very good. Yes, Vikas, Mehak, yes, it is echolalia. So the answer of this question is perseveration. Another very interesting question again, this topic of organic mental disorder again is very important. So you're planning, you're preparing for all the upcoming exams. This is a very important topic. Many questions have been asked recently from this topic. So the question is, a 70-year-old male presents with symptoms of forgetfulness, difficulty in combing his hair. He has visual hallucinations. After a year of onset of these symptoms, he also has developed rigidity and bradykinesia. So what is the likely diagnosis? So again, it's a very interesting question. A similar question was asked in NEET PG 2023. So I've just twisted the question and also changed the option. Let's try to see if we can answer such questions. So very important, please try to see. So yes, we're talking about dementia. So the person has forgetfulness. What is this symptom? Very good. So we have two. So most of you are saying it is D. And why cannot this be C? Why cannot this be C? Okay, let us say even Lewy bodies are also seen. So in the histopathology, let us say even Lewy bodies, let me say, are seen in the patient. So this is a very important point I want you to understand. Lewy body, first of all, Lewy body dementia is a very important topic again, if you see, it was there in the option or in the answer, in the last few exams. So it's very important topic. I'll tell you why. So why is it very good? Yes, Yogesh, Dr. Benedict, Dr. Nisi, why is it not C, or why, why is it C or not D? Again, let's try to see first the symptoms. Let's see, beta. He is having forgetfulness, that is, there is amnesia. So there is amnesia. Difficulty in combing the hair, so there is problem in fine movements. There is apraxia. So there is cognitive, impairment is there. Visual hallucinations have also been, given. Now please remember one point, very important point which I am making is that visual hallucinations, again, when you see in the question or in the, in any case, again, may suggest of organicity. So most common hallucination in organic mental disorders, are visual hallucinations. So this is a very important point. So we have visual hallucinations, and after some time patient has developed symptoms of rigidity, bradykinesia, Parkinsonism like symptoms patient has developed. So let us try to see. So let's try to understand what is Lewy body dementia. What is Lewy body dementia? Very good. So we know there are 3 core features. Very good. So 3 core features of Lewy body dementia: fluctuating cognition, there is cognitive impairment, visual hallucinations are seen, and motor features of Parkinsonism such as tremors, rigidity, bradykinesia are seen, which are seen in this case. And we have also, written that, let us say that Lewy bodies are also seen. So Lewy body dementia seems to be one of the options, isn't it? So how to differentiate? So when we talk about Lewy body dementia and Parkinson's disease, so even in Parkinson's disease, along with, tremors, rigidity, bradykinesia, you can have cognitive, impairment, you can have visual hallucinations. And one very important point which you should remember is Lewy bodies, as the name suggests, are not just seen in Lewy body dementia, they can also be seen with Parkinson's disease. So both of them are close differential diagnosis of each other. So how then should we differentiate between Lewy body dementia and Parkinson's disease? In the question asked in NEET PG 2023 was, they had not mentioned Lewy body dementia, so the answer was Parkinson's disease. How can we differentiate? Can anybody tell me? Visual hallucinations can be seen in Parkinson's also. Very good, doctor, very good, Amit. Yes. So clinically we can differentiate, very good, in Lewy body dementia and in Parkinson's disease. So in Lewy body dementia, what we see is cognitive impairment would occur along with, so it would occur in the beginning, in the initial presentation, along with the motor symptoms. So motor symptoms may occur in the beginning or may occur at later part. While in Parkinson's disease, we see that the motor symptoms would occur first. And clinically it is seen that after 1 year we will have cognitive impairment. So this is a very important point to clinically differentiate Lewy body dementia and Parkinson's disease. So now can you see here the patient has, so cognitive impairment has started first, and later on the person has developed rigidity, bradykinesia. So that is why the better answer is option C. Is it clear to everyone? Very important, point. Dementia is a very important topic. We'll talk about some of the important drugs also. So is it clear to everyone? Is this point clear to everyone? There is also one important suggestive feature. Important suggestive features are also there. One of the important suggestive features is that they are sensitive to antipsychotic induced EPS. We'll talk about EPS, extrapyramidal symptoms which occur with antipsychotics. So if you give antipsychotic in this patient, they are more vulnerable to develop those extrapyramidal symptoms. So if you have to give antipsychotics which are less prone to EPS and start with low dose. So this is another important point. Now can anybody tell me, this is again a very important point, which is the overall most common dementia? Which is overall the most common dementia? Again, this is a very important point which I am discussing, highly important for your upcoming exams. Can anybody tell me which is the overall most common type of dementia? Which is the overall most common type of dementia? It is Alzheimer's dementia. Okay, it is Alzheimer's. Most common is Alzheimer's. Very good. Yes, it is Alzheimer's dementia. Can you tell me which is the second most common? This is very important. Suppose they don't give Alzheimer's dementia in the option. So which is the second most common cause of overall dementia? Most common. This is very important. The question is, I'll repeat. Yes, Anup, I'll repeat. Which is the most common dementia overall? So one, I have told you Alzheimer's dementia. Which is the second most common? Which is the second most common dementia? Very good. So earlier it used to be vascular dementia, now it is Lewy body dementia. This is very important point. Again, Lewy body dementia is a very important topic. Again, you should know. Also in dementia, do read about reversible causes of dementia. So do read about reversible causes of dementia. Again, we have been discussing this topic. Even INI-CET again has asked this, some of the important causes such as, NPH, normal pressure hydrocephalus, vitamin B12 deficiency, even hypothyroidism. All these have been asked in the recently asked INI-CET exam. So do read about reversible causes of dementia. Again, dementia is an important topic. I hope this is clear. This is a very important topic one should know about. Okay, now this is a new question. It's a FQ, again very important, yes. Rushabh, very good. Yes, hypothyroidism is one. Very good. Yes. Now this is a very important question. Let us see if we can answer this. So along with cognitive impairment, we know in dementia, very good. In dementia, we have a neuropsychiatric symptoms in the patient. Patient may have delusions, hallucinations, agitation. Patient may have personality changes may occur in the patient. Patient may have, very good, patient may also have symptoms such as depression, mania, anxiety. So neuropsychiatric symptoms can be seen. The question is, a 60-year-old male diagnosed with Alzheimer's dementia presents to you with severe agitation. So which is the drug FDA approved for this indication? Again, this is very important. Very good. Very good. This is a very important question. Again, maybe a new question in the upcoming exams. So usually when we have delusions, hallucinations, agitation, we can use drugs such as olanzapine, quetiapine, haloperidol. Again, these are antipsychotic drugs, but FDA has approved one drug for this particular indication of agitation in dementia due to Alzheimer's disease. Which is that drug? Very good. All of you are right. It is brexpiprazole. So again, it is very important, just recently approved drug. It's a second generation atypical antipsychotic drug. It is a partial D2 agonist like aripiprazole. So again, this is very important question. Please remember this. So this is again very important. Very good. So all of you are correct. Yes, Riya, Mithu, Superstar, Krishna Kumar, Art Time, Priyanka, Amit, Pranoy, Dr. Tariq, Ruxana, Rajat. Very good. Mehak, Priyanka, Anup, Amit, very good. Achan Khan, very good. So it is correct. Now let us again, so this is one new drug. Again, I'll also talk about another important drug. Again, we have this drug in the videos as well, but let's try to understand about the treatment when we talk about treatment of dementia. So in the treatment of dementia, again, I'll just briefly discuss. We know there is decrease in the acetylcholine. So we have drugs, that is cholinesterase inhibitors, which increases the acetylcholine. We know there was tacrin. Tacrin is no longer used. Why? Because it is hepatotoxic. It is hepatotoxic. And then we have other drugs such as donepezil, rivastigmine, galantamine. Okay, so these are some of the drugs which usually we start a patient with. Then we also know that there is a increase in the glutamate. So glutamate is increased. So we have memantine. What is the mechanism of action of memantine? Can anybody tell me what is the mechanism of action of memantine? The mechanism of action of memantine is, it is a NMDA antagonist. It is a NMDA antagonist. What is NMDA? N-methyl D-aspartate. It is a glutamate receptor. It is a glutamate receptor. So we know glutamate is increased. We are using an antagonist. Usually it is used for moderate to severe cases. And we have formulations which combine donepezil and memantine. So it may also be given in combination. Okay, so these are some important points about memantine. Now let's talk about, very good. Yes, Chandni, Dr. Benedict, very good. Yes. So let's talk about some of the other drugs which we have. So earlier these drugs were used which would not cure dementia but would slow down the progress. Now we have two drugs. This again, I'm sure we must be knowing aducanumab. Can you remember? Yes, you can. Aducanumab. The name is telling you it is a monoclonal antibody. It is a human IgG1 monoclonal antibody, which basically it clears the A beta deposits. So it helps in clearance of A beta deposits. So it was, again FDA approved, in 2022. So it is particularly used for, since it is removing A beta deposits which occur in which dementia? In Alzheimer's. Very good. So yes, it helps to prevent. Yes, very good, Vikas, Amit. So basically it is used in Alzheimer's disease. Okay, in Alzheimer's disease. So aducanumab. Now in 2023, now recently only, so this drug lecanemab. So can you remember? Yes, you can. Lecanemab, again, please remember this drug was, in the accelerated approval by FDA. It was approved in January 23. Now they have also approved in July by their traditional method. So again this drug becomes important. Lecanemab, it is humanized monoclonal antibody. Again it targets A beta deposits. So this is again a very important drug. Please remember this. Lecanemab, again it is used for Alzheimer's dementia. So this is another new drug one should be ready with. So such questions on new drug, again this topic has been asked so many times, and since there are new drugs in this topic, so again these questions may come in the exam. So I hope this is clear to everyone, and of course for neuropsychiatric symptom we can treat according to the symptom. I hope this is clear to everyone. Right, let's talk about the next question. Again, so we are trying to, again, a lot of questions in psychiatry come, especially with psychopharmacology. So there is a lot of integration with pharma. So let's try to understand some of these symptoms so that we can understand the clinical scenario and what treatment to be done. A 34-year-old male presents to the psychiatric outpatient department due to twisting of the neck to one side for 5 hours. So there is a sudden acute, contraction of a group of muscle leading to torticollis, and the person is in severe extreme pain. Now he presented a week ago due to delusions and hallucinations and was started on antipsychotic drug. So patient was having delusions and hallucinations. So he was started on antipsychotic drug, and the physician is suspecting adverse effect due to the antipsychotics. Which of the following is the preferred treatment? First, can you tell me what could be the diagnosis in this case? So again, we have not been given the duration. We have not been given the duration, but we know patient has delusions and hallucinations. So what could be the diagnosis? So there could be, two diagnoses. One, of course, it can be schizophrenia. It can be schizophrenia. And of course, since the duration is not given, it could also be acute psychosis. Okay, acute psychosis, very good. And the person has developed, very good. Person has developed EPS, very good. Person has developed EPS, acute dystonia. Can you tell me why, why generally this EPS would occur? So we know antipsychotics, they are blocking, or they are dopamine antagonist, especially D2 antagonist. So why the person develop these EPS such as acute dystonia? So why? Because there is a tract, dopamine tract in the brain, that is nigrostriatal pathway. That is a nigrostriatal pathway. Let's try to understand this. Very good. I'm sure all of you know that it is acute dystonia, and by now I'm sure you know that the treatment is anticholinergic drug. Very good. So nigrostriatal pathway. Let's try to understand some of the important basics. Let's try to understand this. But a nigrostriatal pathway, it is going from substantia nigra to the striatum. If we remember our knowledge of medicine, we know there is Parkinson's disease. In Parkinson's disease, usually what happens to the dopamine levels in this tract, it decreases. That is why we give levodopa. So when in Parkinson's disease, in this tract, the dopamine level decreases. So what kind of symptoms person has? Person has symptoms such as tremors, rigidity, bradykinesia. So because of low dopamine in this tract, the person has motor symptoms. Now can you relate it with antipsychotics? Now, very good. Now can you relate it with antipsychotics? Very good. So in antipsychotics, What are we doing? We are giving D2 antagonist. We are giving D2 antagonist. So they will also decrease, or they will also antagonize dopamine in this pathway. So because of decrease in dopamine in this pathway, we are getting EPS. So few things I am going to tell you again, very, very important. Also, how, let's try to also understand why do we give anticholinergic drugs, to treat these symptoms. Very important is acetylcholine, or you can in fact say dopamine in this tract is inversely proportional to acetylcholine. Again, very important. So dopamine is inversely proportional to acetylcholine in this pathway. So when we use anticholinergic drugs, we decrease acetylcholine, and subsequently what will increase? Dopamine will increase, and it will help in the treatment of these symptoms. I hope this point is clear. These are some of the important conceptual points which I am discussing. Okay, is it clear to everyone? Yes. Yes, so let's try to understand, let's see some of the EPS. Acute dystonia, as we know, it is earliest and sudden onset of symptoms with sudden contraction of muscles, such as patient may have oculogyric crisis, uprolling of eyes, there may be torticollis, laryngospasm. Yes, and anticholinergic drugs such as we can give, because it is very, very distressing for the patient, we can give IV promethazine. Then drug induced Parkinsonism may also occur. What is the treatment? Again, anticholinergic drugs such as trihexyphenidyl can be used in this condition. So patient may have tremors, rigidity, bradykinesia. Very good, very good. Let's talk about some other EPS. Akathisia, again akathisia, it is the most common EPS where the person has restlessness. So patient will say, so you may be given a clinical scenario, patient is saying I am restless, and objectively also you can see the person is appearing restless. He is pacing around, not sitting at one place, he is moving, tapping his feet. So the person is objectively also appearing restless, and the treatment is propranolol. The treatment is propranolol. Tardive dyskinesia, tardive means long term, dyskinesia means abnormal movement. Sometimes after long term use of antipsychotic, patient may develop certain abnormal movements such as lip smacking, or patient may have chewing movement, or tongue protrusion, or coriform movements or piano movements of the hands may occur, and here we use VMAT2 inhibitors, that is vesicular monoamine transporter 2 inhibitors. These are dopamine depleters such as valbenazine, tetrabenazine. So again I am trying to just talk about some of these important side effects which can occur and can be given clinically in the question. And lastly, we can also have neuroleptic malignant syndrome. Again, as the name suggests, malignant, it is again life threatening, wherein after on antipsychotics, patient may come to you with high grade fever, increased CPK levels, muscle rigidity, sweating, tachycardia, patient is disoriented, patient is confused. So such symptoms if occurs, what is the treatment of choice? It is dantrolene. We can also use certain dopamine agonists such as amantadine and bromocriptine. So I hope these important side effects, very good, these important side effects are clear to you. Again, such type of question may be asked in the exam. I hope this is clear to everyone, right? Now let's talk about the next question. So a 40-year-old male, so let's talk about this next question. A 40-year-old male presents to the psychiatric outpatient department with symptoms of claiming neighbors wanting to kill him, and also hearing their voices not heard by others. These symptoms have been present since 2 years. He was started on haloperidol, thioridazine with not much improvement. Haloperidol, thioridazine, these are typical antipsychotic drugs. These are typical antipsychotic drugs. Patient comes to the OPD with the symptoms. So he was started on a new drug, you started him on drug A. So patient comes to the OPD with symptoms of sore throat, fever. His WBC count was decreased and subsequently you stop the drug. Which of the following is the most common side effect of the drug A? So are you able to appreciate what has been asked? So you've been given a clinical condition in which you have started a drug and they have given you one side effect, and now they're asking which is the most common side effect of this drug. So first of all, tell me, very good, what is this condition? First of all, let's try to understand. Patient is having suspiciousness, that is delusions, and he's also hearing voices, hallucination for more than 6 months, so it is 2 years duration. So we know the diagnosis is very good. The diagnosis is schizophrenia. Very good. So schizophrenia, again we'll try to understand some important questions which may come from this topic. Very important. And subsequently there was no response to 2 antipsychotic drugs. 2 antipsychotic drugs have been given with no response. So this seems to be treatment resistant schizophrenia. So patient with treatment resistant schizophrenia comes to you, which is the drug, which is this most likely drug? Very good. So yes, Dr. Nisi, yes Afsar, yes Jaideep, it is, yes Chandani, Dr. Yes, it is. What is that drug? It is clozapine. Clozapine is used for treatment resistant schizophrenia. And now when you see the WBC count is, the patient comes to you with infection, so throat fever, it is suggesting that the WBC count is decreased. So there is agranulocytosis, so you stop the drug. So what is the most common side effect of clozapine? It is sedation. Very good. So the answer is very good, Rishabh, Dr. Benedict, very good. So again, I have tried to ask certain things in this question. So again, if you have a good knowledge of these drugs, then we can answer these questions. So let us try to just quickly understand some of the important points with clozapine. We know it is the second generation antipsychotic drug. Second generation are D2 and 5-HT2 antagonists, but in clozapine, it works more on D4 than D2. That is why we say it is one of the drugs with least EPS. Least EPS, because EPS occurs because of D2 blockage. Antipsychotic with anti-suicidal property, you should know, which is the mood stabilizer with anti-suicidal property. Mood stabilizer, if we talk about with anti-suicidal property, is lithium. Again, lithium is a very important drug. It is used for treatment resistant schizophrenia. So if there is no response on 2 antipsychotic drugs, then we say it is treatment resistant schizophrenia. Very good. So which is the most common side effect of clozapine? It is sedation. So usually sedation occurs because of blockage of NH1. So because of H1 blockage, there is sedation. Cyalloria also may occur in these patients. Again, cyalloria has different mechanisms such as M4 agonism, alpha-2 antagonism, even decreased swallowing. So if a person with cyalloria on clozapine comes to you, again, this is an important point which we are discussing. What is the first step you may do? So this, cyalloria is occurring, one of the mechanism is decrease in the swallowing. So one simple, technique or simple tip which we give to the patient is put a towel over the pillow while you sleep. So what happens? It will prevent the soiling of the bed sheet and the pillow. So this is one first step which you may do. So again, such type of question may be asked. Hypotension may occur, weight gain may occur. Again, we know that second generation antipsychotics, they can give rise to metabolic side effects. Metabolic side effects. Now, can you tell me, so weight gain out of these drugs, maximum weight gain is with clozapine. Can anybody tell me? Very good. Very good. Can anybody tell me what is the mechanism of weight gain and these metabolic side effects? Again, important, blockage of which receptor leads to these metabolic side effects? Please remember metabolic side effects. Please remember metabolic side effects occur because of 5-HT2. Please remember C antagonism. Very important. This was asked also in your exam. Please remember metabolic C, 5-HT2C. So you can remember it like this. Metabolic side effects occur because of blockage of 5-HT2C receptor. Very important. Okay. Even constipation, anticholinergic side effects are also seen. So these are some of the common side effects which we get with clozapine. Again, coming to the serious side effects, I am sure all of us know. Okay, so serious side effects, you can remember it with a mnemonic, that is seizures. Seizures may occur, and if seizures occur, then what will you do? Again, it is dose dependent, so it occurs on higher doses. And if seizures occur, you can give treatment with anti-epileptic drugs. You can treat it with the anti-epileptic drugs. We will come to this point. I will talk about one important question in this. So second is agranulocytosis. Agranulocytosis, there is decrease in the WBC count, decrease in the absolute neutrophil count. So again, if person develops agranulocytosis, what we have to do is we have to stop the drug, as in this case we have stopped the drug. Okay, so again this is important, and it is so important, the side effect, that it requires regular monitoring. Okay, so when I start, when we start any patient on clozapine, for the first 6 months we do weekly blood counts, and then after that for the next 6 months, every 2 weeks we check the WBC and the absolute neutrophil counts. So this question also was asked in your exam, that which side effect of clozapine requires blood monitoring, regular blood monitoring. Okay, so again I have tried to give you, in this question I have given you a clinical scenario which is suggesting that person has agranulocytosis. So regular blood monitoring is required. Okay, and lastly, person may have myocarditis. So person on clozapine comes to you with chest pain, abnormal ECG, tachycardia. Which side effect will you think of? You will think of myocarditis. So these are certain clinical situations which may be asked in the question. Now another last question which I want you to remember, tell me, so suppose you have started a patient on clozapine with seizure with any anti-epileptic drug. The question is, which of the following, they may give you, options with anti-epileptic drugs, and they ask you which important anti-epileptic drug is contraindicated with clozapine. So again, such clinical questions may be asked, very important. So what we are trying to do is we are trying to cover all these important MCQs. Can anybody tell me which is the anti-epileptic drug which is contraindicated with clozapine? What is the answer? Which drug is contraindicated with clozapine? Can anybody tell me? Please remember, so this drug has agranulocytosis as a side effect. Very good, Achan Khan, very good. It is carbamazepine. Very good. It is carbamazepine. Carbamazepine has a side effect of bone marrow suppression, again a lethal combination if we give it with clozapine. So again, such questions may be asked. So please add on to your notes, such questions may come in the exam. So this was about clozapine. Now just before finishing, again, since a lot of integration is occurring, and sometimes they may ask questions related with ophthalmology also. Can you tell me, so a patient comes to you with on antipsychotic with corneal and lenticular deposits. So you may be given a clinical question that a person on antipsychotic comes to you, and ophthalmology image may be given that a person has corneal or lenticular deposits, or another scenario in which they may given a image of the retina and they may say that there is retinal pigmentation. So again, such type of integrated question, again they have been asking so many such image based question. Even in FMGE exam they had asked some questions. So can you tell me which antipsychotic drug may cause, corneal and lenticular deposit, and which can cause retinal pigmentation? Retinal pigmentation, we had just discussed one antipsychotic we had given to this patient, thioridazine. Please remember it like this. Thioridazine can cause retinal pigmentation. Okay, thioridazine also increases QTC interval, and it is one of the drugs with least EPS among the first generation. So these are some important points about thioridazine. Can anybody tell me which is the, very good, which is the, yes, even yes, quetiapine also, yes, one very important drug, very good, chlorpromazine, yes, chlorpromazine, very good. Corneal, please remember, corneal chlorpromazine, very good. Okay, is it clear to everyone? These are some important drugs. Yes, quetiapine, yes, for lenticular deposit, yes, it can also do. Okay, is it clear? Such questions related with images may come in the exam, so be prepared with some of these questions. So let's come to the next question. A 50-year-old man comes to you in the clinic complaining of poor appetite, fatigue, decreased energy for last 2 years, has lost interest in book reading that he used to love, has feelings of guilt, is even having suicidal ideas for 2 weeks, and is extremely worried about it. The physician notices something over the upper eyelid, as you can see in the image. Yes, right. So which of the following sign is present in the image? So what is this sign over the upper eyelid? Please try to see what is the answer. So we have two important signs, clinical signs in depression. Let's try to see. So in the So this triangular fold over the upper eyelid, this triangular fold, what is this known as, beta? The diagnosis in this case all of us know is depression, as they have given all the symptoms suggesting of depression. And what is this fold over the upper eyelid? So there is, it is, yes, it is Variguth fold seen in depression. What is B omega sign is also seen, we will talk about this. So omega sign in this case is not omega sign is seen on the forehead at the root of the nose. Okay, of course it is not in mania. And what is Russell sign? Of course Russell sign is not seen in depression, but Russell sign is seen in which condition? In which condition do we see Russell sign? Anybody? So again, where do we see Russell sign? In any eating disorder? Yes. So let's talk about what is this is omega shaped sign. This is omega sign. Very good. This is omega sign. Yes, Chandni. Yes. Omega sign. What is Russell sign? Russell sign is basically these callus formation on the knuckles, these callus formations on the knuckle which occur because of repeated self-induced vomiting, purging. So again they may be seen in bulimia nervosa, and they can also be seen in anorexia. In anorexia we know there is a binge eating purging type, even in anorexia nervosa it may be seen. Okay, so this is Russell sign. Russell sign is seen in eating disorder because of self-induced vomiting. It's a complication of purging. Very good. So the correct answer here is Variguth's fold. Okay, is it clear? These occur basically in patients especially having chronic depression because of contraction of the facial muscles such as the zygomatic and the corrugator muscles. That is why these signs occur in depression, Variguth's fold and omega sign. Okay, is it clear to everyone? Very good. Yes, correct. Let's talk about this again, a very important topic, pregnancy and psychiatry. Many questions have been asked related with pregnancy and psychiatry. A 28-year-old female, since 2 weeks after her full term normal vaginal delivery, started having decreased sleep, anger outburst, irritability, and few days later she started saying that the baby born is not her baby, but it is the baby of the devil and she wants to kill the baby. She also reports of hearing voices of the neighbors telling her to kill the baby. Which of the following is the likely diagnosis? So 2 weeks after the delivery, the patient had certain prodromal symptoms such as sleep disturbance, anger outburst, irritability. What is this symptom when she claims that the baby is not her, that that is the baby of the devil? She is again it's a false belief, fixed belief, and she wants to kill the baby because of this. So she is totally convinced. So this is a delusion. This is delusion. And she is also hearing voices of the neighbor telling to kill the baby. Very good. This is hallucination. So delusions and hallucinations, very good. After the delivery, it is postpartum psychosis. Very good. It is postpartum psychosis. Very good. So again, this is very important. Such questions may come. Let us just quickly discuss postpartum blues. Very good. Yes, Vikas, Afsar, Dr. Benedict, very good. Rushabh, Gangaram Chaudhary, very good. Rajat, Akshan Khan, Ruxana, very good. So all of you are correct. It is, so let's try to understand what is blues. Again, blues are milder symptoms, may occur in 30 to 75% of the females after delivery, usually have an onset 3 to 5 days after delivery, and may it is again it is transient, so there is spontaneous remission. And transient symptoms such as sadness, irritability, tearfulness, decreased sleep may be there, and there is no specific treatment is required, only supportive care is enough. When we talk about postpartum depression, again seen in 10 to 15% of the females after the delivery, and sometimes DSM-5 uses the term peripartum onset, so in which depression occurring in pregnancy or within 4 weeks, some books say 6 weeks, so you can say 6 weeks of delivery, having depressive symptoms, having more severe symptoms such as anhedonia, such as excessive guilt, suicidal thought, then you will think of depression. It is fulfilling the criteria of depression. Again, treatment is required. We will treat with drugs, CBT we can treat, and we also have one drug which is approved by FDA for postpartum depression. This is a GABA. This is a GABA A modulator. This is a GABA A modulator, And lastly, so we have questions on blues and depression. So, but we don't have recently asked question on psychosis. So, I've given you this question so that you should be prepared. Such questions may come. Postpartum psychosis, even less, prevalence. It is again patient having delusions and hallucinations, starting with sometimes prodromal symptoms, such as in this case, person develops delusions and hallucinations, and many times they are related with the baby, as in this case. So, what is the treatment? Treatment is antipsychotic drugs. So, again this is very important. Good morning. Yes. Hello Sanjay. Yeah. So, very good. So, again I hope it is clear to everyone. Be prepared with such questions. Many times they are asking questions on pregnancy and psychiatry. Is it clear to everyone? Very good. Now, let's talk about this next question. Again, I've asked some of the important side effect of many of these antidepressants in this question. A 25-year-old female was taking medication for depression, and which of the following statement you have to say is incorrect? So, you have to tell the incorrect regarding the antidepressant medication. So, let us see. So, no order, Dr. Nisi, it can occur, but I am trying to say that if any occurs, you should know how to make a diagnosis. So, usually postpartum blues would occur in the initial days. Postpartum depression would occur within 6 weeks, and even postpartum psychosis would occur during this time, and usually with delusions and hallucination. This is how we will differentiate. Okay, so which is the correct answer? You have to see the incorrect. Yes, very good. Which is the incorrect? Which is the incorrect? Can you tell me? So, first tell me, is A correct or not? SSRI, SNRIs can cause sexual dysfunctions. It is correct. They can cause less sexual side effect. This is a very important question. It has been asked in many times in your exams. Drugs with least sexual side effect. Sometimes the option is bupropion, sometimes it is mirtazapine. It is also correct. Paroxetine should be avoided in pregnancy. Again, this is a very important point. Please remember, it is also correct. Most of the SSRIs we can give in pregnancy. They are not teratogenic, but please remember, contraindicated or which is teratogenic in pregnancy. P for pregnancy, P for paroxetine. Please remember, because it causes cardiovascular defect. So, again this is a prospective new question. Please remember this. So, this is also correct. Bupropion is safe in comorbid bulimia nervosa. Again, please remember, it is an incorrect statement. Let's try to understand some of the important side effects of these. So, depression, we know the drug of choice in the pharmacotherapy are SSRIs. SSRIs have less side effects. So, these are the drug of choice. So, these are some of the important SSRIs which we use. In side effect, few points about SSRIs you should know is, which is the most common side effect? Nausea is the most common side effect. Which is the most common long-term side effect? Which is the most common long-term side effect? Sexual side effect. Most common long-term side effect with the SSRIs, it is the sexual side effect, okay, such as decreased libido, delayed ejaculation. Okay, so many times because it delays ejaculation, we use it in the treatment of premature ejaculation. Okay, so sexual side effects occur, can occur with SSRIs, even with SNRIs. Vivid dreams, sweating. Also, please remember, dry mouth also is a side effect. Previously in AIMS, before INI-CET, twice they had asked this question in the exam, that which of the following is not a side effect with escitalopram. Escitalopram is an SSRI, and one option was dry mouth, one option was cyalorrhea. Please remember, dry mouth can occur. And in elderly, you may also get hyponatremia, especially elderly. Okay, so these are some of the important side effects, and we talked about pregnancy. P for paroxetine, avoid in pregnancy because it causes cardiovascular defect, teratogenic effect in the pregnancy. This is again important. All the other SSRIs, if we give in pregnancy, they are not teratogenic, but what they can cause in the infant, again this was also INI-CET last year question, it can cause pulmonary hypertension in the infant. Other also effects are also there, such as autism, ADHD, delayed growth. All these can occur, but they have studies are showing inconsistent, but yes, many studies have shown pulmonary hypertension in the infant. So, in the question of INI-CET, all was the option. So, all was the answer, but if they ask one, again pulmonary hypertension. Very good. Is this clear to everyone? This one slide had many questions of your exams. I hope this is clear. So, all these are very high yielding points what I am trying to discuss, so that We discuss a lot of these questions. Now coming to SNRIs, again you should know some of these SNRIs, okay, such as venlafaxine, desvenlafaxine, duloxetine, milnacipran, even levomilnacipran, So these are some of the important SNRIs. So SNRI side effects are similar to SSRIs. So they also cause sexual side effect, and also you can remember venlafaxine, desvenlafaxine, at higher doses may also have a side effect of hypertension. So these are some of the important. So SNRI means serotonin norepinephrine reuptake inhibitor. So they are affecting both serotonin and norepinephrine. This question was asked in an FMG exam. A psychiatrist has given a drug which affects serotonin and norepinephrine, which is that drug. So indirectly they were asking you an SNRI. I hope it is clear to everyone. Very good. Let's talk about this next drug, again very important, NDRI. So bupropion, again very important, NDRI, norepinephrine dopamine reuptake inhibitor. So these are basically the three, mono means, hypothesis of depression says that there is a decrease of serotonin, norepinephrine and dopamine. So this drug is affecting norepinephrine and dopamine. So usually sexual side effect occur because of serotonin. So this drug is not affecting serotonin much. So that is why there is a low risk of sexual dysfunction, okay, in this drug. So this is again very, very important. Another drug which I have just talked to you, having least sexual side effect, is mirtazapine. Now there is one important FQ or a future question which I want you to remember is, beta, this drug has one side effect. What is the side effect? The side effect it can cause is seizure, especially at higher doses. So since it causes seizure, this is contraindicated. This is again a very, very important prospective question for you, in which psychiatric disorder it is contraindicated. Contraindicated in disorders such as bulimia nervosa and even in anorexia nervosa. Why it is contraindicated? Because in bulimia nervosa, a person is having compensatory behavior such as self-induced vomiting. So electrolyte imbalance is there. So they are at risk of seizures, and bupropion also causes seizure. So there is an increased risk of seizure. Even in anorexia, patient is not eating, is in a state of starvation like state. So again, because of complications such as electrolyte imbalance, they are also at increased risk of seizure, and this drug has a side effect of seizure. So this is very important. Books mention that it is contraindicated. I hope this is a important point you should remember. I hope it is clear to everyone. Right, great. So let's come to the next question. So a 20-year-old Geeta presents to the clinic with her mother, complaining that the size of her ear is not perfect. Her mother reports that Geeta is preoccupied. So mother says she is preoccupied with her ear size and repeatedly looks into the mirror. Although her ear size is normal and the examination is also unremarkable, what is the possible diagnosis she is suffering from? So she has very good. Now very good. So the answer seems to be yes, it is body dysmorphic disorder. Very good. This is the right answer. Very good. So it is not OCD. She is preoccupied with an imagined body defect. Please remember the word preoccupied. But there is also a hypochondriacal delusion. Can anybody tell me any hypochondriacal delusion? Any delusion which is also similar? Any delusion which may also have similar effects? So this point I want you to understand is, please remember, no, don't do, send to the Dr. Benedict, send to the psychiatrist. Don't do surgery. The person may sue you. Okay. So because their problem is in the mind. Okay. So can anybody tell me any hypochondriacal delusion related with the with the body which may be similar? It is delusional. Please remember, but it is delusional dysmorphophobia. Even in delusional dysmorphophobia, dysmorpho means, dys means abnormal, morphic means morphology. Even here also the person has these beliefs that there is something abnormal with my body. But please remember, this is a delusion, this is a fixed belief. This is a fixed belief, while in body dysmorphic disorder, it is a preoccupation. So patient is not totally convinced. So sometimes when you say no, it looks fine, patient may also say yeah, it may appear normal to them for some time, but they are again preoccupied that there is something abnormal. So here again they use this word preoccupation. So suppose they say that she is visiting many doctors and she is not getting convinced. If they use such terms, then you have to think of delusional disorder such as delusional dysmorphophobia. So again, this is a very important close differential diagnosis which I want you to understand. Again, this question is from again from the QBank only. So again, Okay, so please remember this. Both can be the answer, but it is a preoccupation. Very good. So since it is a preoccupation, that is why it is body dysmorphic disorder. Is it clear to everyone? Not growing per se, but yes, something is abnormal. Yes, there is something abnormal. It can be, different ways. Paras, yes. Is it clear to everyone? So basically body dysmorphic disorder, as we had discussed, it's a preoccupation. The person is preoccupied with some imagined defect in the appearance. Now one important point, I want you to remember is that we know in DSM-5 there is, obsessive compulsive and related disorder. It's a new entity which has been added, which includes OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, that is hair pulling, and excoriation disorder. So now body dysmorphic disorder is under obsessive compulsive and related disorders. Even ICD-11 has also made a similar category. Few changes I want you to remember, because one of the question was asked in the exam, and so questions may come from this table also. So they also have included OCD, body dysmorphic disorder, hoarding disorder. Now they have introduced a new term, that is body focused repetitive behavior disorder. So they have introduced a new term, body focused repetitive behavior disorder, as the name is suggesting that something is focusing on the body. So body focused repetitive behavior. So here they have included trichotillomania and excoriation disorder. Okay, so this question was asked in INI-CET, that which of the following is included in body focused repetitive behavior disorder in ICD-11. Now, since this question was asked, let us also try to understand some of the other changes. They have introduced this term olfactory reference syndrome. Please remember, beta, this is again important, olfactory reference syndrome. What is olfactory reference syndrome? Here the person is preoccupied that one is emitting some foul smell. So patient is preoccupied that there is some foul smell coming from his body. Please remember, he is not able to smell it. If he says he can smell it, then it may go towards olfactory hallucination. Okay, it may go towards olfactory hallucination. He says he believes there is a preoccupation. So he says that, he feels that there is some foul smell coming from his body. This is olfactory reference syndrome. So this is a new entity. They may ask question on this. And also one other term which is included in ICD-11 in this category is hypochondriasis. Hypochondriasis is preoccupation. Patient is preoccupied of having a serious illness. So patient may say, sir, I feel that I am having brain tumor, I feel I am having abdominal tumor. So such serious illness the person is preoccupied or worried about. So this is also included in ICD-11. So I hope, very good. Yes, Dipanjali. Yes, serious illness. Very good. So I hope this is clear to everyone, right? Again, this is very important. Such questions, as you can see, have been asked, previously in INI-CET. So such questions may be asked. Now, let's come to the next question. Patient consumes alcohol daily and develops symptoms of global confusion, ataxia and other associated symptoms. So which is the most appropriate? No, it is not normal. It is not normal. Which you are talking about? It is not normal. It is a disorder. That is why we are talking here. Okay, it is not normal. Yeah. So what is the answer? What is the answer? First of all, tell me what is the diagnosis? A patient consuming alcohol and having some, neurocognitive symptoms such as confusion, ataxia. So we know it is Wernicke's encephalopathy. Very good. And in Wernicke's encephalopathy, we know it is because of deficiency of vitamin B1 thiamine. So we'll give thiamine. So the question is, will you give thiamine first, then dextrose, or dextrose followed by thiamine? So again, please remember, if you give dextrose first, so what will happen? Again, the glucose will not be metabolized by Krebs cycle because thiamine is deficient. Thiamine is required for various enzymes. So again, that may precipitate Wernicke's encephalopathy. So always in these cases, give thiamine followed by dextrose. So that is the correct answer. Very good. Benzodiazepines will talk about, Dipanjali will talk about benzodiazepines. They will be used in withdrawal. I am not talking about withdrawal right now. I am talking about neurocognitive disorder associated with alcohol. So this is what we are talking about right now. Alcohol induced neurocognitive disorders such as Wernicke's encephalopathy and Korsakoff syndrome. Very, very important. NEET PG 2023, 2 questions came from just this topic. So this is again very important topic. So Wernicke's is usually acute in onset, while Korsakoff is more of chronic. The symptoms of Wernicke's you can remember with the acronym GOA. global confusion, ophthalmoplegia, there may be debated of the eyes, sixth cranial nerve affected more than third, and ataxia, patient is falling. So in this case they mentioned global confusion, ataxia and other associated symptoms. The diagnosis was Wernicke's encephalopathy. And what is the cause? It is because of deficiency of vitamin B1, that is thiamine, and treatment is also thiamine. So you will give, in the treatment you will give thiamine. So this is very, very important. Is it clear to everyone? Now let me give you one extra point again. Such questions may come, let's try to understand. Suppose in the question, so I'm sure all of us know till now, this is clear to everyone. We know Wernicke's is reversible, while Korsakoff, which has amnesia, anterograde more than retrograde. So amnesia is there, that is loss of memory, and confabulation also occurs, filling of memory gaps with false stories. It is usually irreversible. Some symptoms may remain. Now the next question which it is Wernicke's usually occurs in acute onset. You may see within few hours symptoms are developed. You give thiamine and generally the symptoms are reversed, right? While in Korsakoff, some of the symptoms, some of the amnesia may remain. Now the next question which I am now going to ask you is, suppose they give you, okay, yeah, very good, yes Dr. Benedict. Now next question is, please try to understand this question. The next question is, they give you this picture. So this is the clinical picture they have given you, and they say that you have given thiamine, and after giving thiamine they say there is no response or no improvement in the patient, no improvement in the patient. Then what is the next step? So are you able to understand? So we say that a picture is of Wernicke's, but there is no improvement with thiamine. What is the next step then? So this may be again a extra edge point for you. What is the next step? What you will do? What you may suspect, because again you may suspect because of again chronic alcoholism, there may be deficiency of niacin. Niacin deficiency may also cause this symptoms, so pellagra encephalopathy like symptoms may also occur. So then next step is you give niacin. So please highlight this in your notes, add in your notes, please remember this. This may be because this is a very important topic, so many questions have been asked. So what if they go one notch further in this approach? I hope this is clear to everyone. Very good, yes. Very good, yes Dr. Benedict, very good. Art time. Sanjay, very good. I hope this is clear. Now next question. A 32-year-old female comes to the psychiatry OPD and she is complaining of constricting headaches and neck pain. So there are somatic complaints in the patient. The patient reports that her symptoms have worsened in the last 6 months after her new job. So she has started a new job and symptoms have worsened. Now her husband reports that she always has a tendency to worry excessively. She worries a lot, even on small thing the female worries. The patient upon further questioning describes that she feels that her mind never stops working and she always is worried about something or the other, job, kids or parents. And she also feels irritable, fatigued because of this. Family history also is there significant for depression in her mother. What is the most likely diagnosis? Can you tell me? So she is worried excessively. Very good, Rishabh, Dipanjali, Dr. Sandeep, Mayank, AD, Paras Patel, Ria, Dr. Benedict. Why? So this new job is added, so don't think of adjustment disorder. Adjustment disorder can occur, but please remember it is a diagnosis of exclusion. When you don't get any other diagnosis, then you think of adjustment disorder. So here, are you able to appreciate any other disorder? So it is not adjustment disorder. It is also not acute stress disorder, because in acute stress disorder the trauma should be first of all very severe, like in PTSD, and the duration is usually less than 1 month, and the symptoms are also not there of acute stress disorder. It is not OCD. She is worried of small thing. Very good. It is generalized. Very good, Dr. Nishi, Vikas, Arshi, Afsar, Mithu, Arsalam, Simbu. Very good, Ruxana, Dr. Benedict. Yes, crazy doctor. Very good, Sanjay 9. Yes. It is GAD. Now just few points again I will tell you. So anxiety disorders wherein the predominant symptom is anxiety. Again panic disorder is very important. Please remember this. It was again recently asked. Sudden onset of anxiety, and what is the key point? Feeling of impending doom. Patient feels, oh my god, I am having a heart attack or I am about to die. Such symptoms occur, and these symptoms occur usually like this, episodically. In between the patient is normal. That is panic disorder. Then there are 3 anxiety disorders which you can consider are situational. So I'm sure you know what is agoraphobia, specific phobia and social phobia. Okay, so these are 3 other anxiety disorders. And generalized anxiety disorder is when the patient has anxiety in nearly every situation. So it is persistent anxiety. Very important symptom patient has is excessive worries. This is known as free floating anxiety. So this is sometimes this is known as free floating anxiety, anxiety on small issues. So again, this is very important to differentiate between these anxiety disorders. Agoraphobia, I want you to remember that there are 5 situations in agoraphobia, and when we say agoraphobia, if anxiety should occur in 2 or more. Please remember, this is very important. So the situations such as, you know, in public transport, in open spaces, in closed spaces, in crowd, or when in a line, and last is when alone outside of the home. So they are the 5, these situations are 5 situations, out of which if anxiety occurs in 2 or more, then we call it as agoraphobia. I hope this is clear to everyone. Very important one point, again it's an epidemiological point, many times you are getting questions on epidemiology. So you can remember this. All the anxiety disorders, if we talk about, this is a very interesting point, please listen to this, a very interesting epidemiological point I am saying. Anxiety disorders, when you talk about all these anxiety disorders, they are more common in males or females? Can anybody tell me? These anxiety disorders are more common in males or females? Anybody? Again, especially, you know, exams like INI-CET, they are asking a lot of epidemiology. Even your NExT, which may occur, we don't know when, but they are also, you know, they are going to ask important epidemiological questions. So can you tell me? Very good. A very good AD. When there is no escape is difficult, that is agoraphobia. Very good. Apsar, Dipanjali 30, Mujulika, very good. Mithu, Dr. Nishi, Rishabh, Riya, Princess Veronica, very good. Females more than males. Can you tell me one exception? This is the point which I want you to remember. So they may ask you in which of the following anxiety disorder it is not more in females. So which is the exception? Can anybody tell me which is the exception? This is important. Please remember, exception is social phobia. In social phobia, it is equal. Please remember this point, very, very important. Such types of questions may be asked. Okay, is it clear to everyone? Very good. Right. Let's come to the next question. Again, a very important topic. A 40-year-old man presents to a casualty with history of regular and heavy use of alcohol since 10 years and morning drinking for one, even started drinking in the morning. Okay, so it is increasing. Very good. Akib, Dr. Disrespect, very good. It was social phobia. Very good. The last alcohol intake was 3 days back and there is no history of head injury or seizure. So they are ruling out any organic, you know, possibility. On examination, there is no icterus, okay, and no signs of hepatic encephalopathy or any focal neurological signs. Patient has coarse tremors, visual hallucinations and disorientation to time. Which of the following is the best medication? So they are giving you everything. They are trying to tell you is that patient has now come to you with alcohol withdrawal. So this is the case of alcohol withdrawal. Can you tell me which alcohol withdrawal are we dealing with? Try to look at the options again. Yashwant, Dr. Disrespect, Dr. N. Kumar. See all the options. Princess Veronica. I am sure if you see all the options, you may find a better answer. Try to see. Very good. AD, Ruxana, Dr. Benedict, Dipanjali. Yes, the diagnosis is delirium tremens. Delirium tremens. Beta, this is very important. Please try to see. So delirium tremens, disorientation they have mentioned. So when they mention terms such as, you know, clouding of consciousness, or they use terms such as altered sensorium, or they use terms such as disorientation, or they use terms such as confusion. All these terms are suggesting that there is impairment of consciousness, suggesting that now the patient has delirium. So let's try to understand. Very good. This is delirium. Let's try to understand these withdrawal symptoms quickly. I'm sure. So alcohol withdrawal, patient is consuming alcohol, now stops. So what are the symptoms? So in the next 6 to 8 hours, patient may have tremors, which is the most common or earliest, you know, symptom. 8 to 12 hours, patient may develop alcoholic hallucinosis, in which auditory hallucination more than visual hallucination. Then 12 to 24 hours, seizures may occur, and these seizures are generalized tonic-clonic seizures, also known as RUM fits. And in up to 72 hours, with a peak in 48 to 72 hours, patient may have delirium tremens. In delirium tremens, we know that visual hallucination is more common than auditory hallucination. And very important point to differentiate, as I've just told you, in delirium, that means there is impairment of consciousness. Impairment of consciousness. Is it clear to everyone, beta? How to make a diagnosis? First of all, you should know how to make a diagnosis. Okay, disorientation to time is suggesting that now delirium tremens have set in. Okay, please don't think that it is always, it will occur in second or third day. Sometimes, if suppose patient has acute infections, in acute infections in withdrawal state, the delirium may occur even early. So don't look at the duration, please look at the symptoms and then make a diagnosis. First of all, this is a very important point. Now coming to the treatment, what is the treatment? Again, we know in detoxification, that is in the withdrawal state, what is the drug of choice? Drug of choice is benzodiazepines. So we may use benzodiazepines such as lorazepam, chlordiazepoxide, oxazepam, diazepam. Now suppose if I ask you if the patient has deranged, so let me write it again. If the patient has deranged LFTs, here they have mentioned that the LFTs, they have shown that no icterus, no hepatic encapsulation, so liver does not seem to be compromised. If the liver is compromised, okay, if the liver is compromised, so it is usually, Sanjana, and it is usually for a chronic case. So it's not that if patient just take for a few months, usually for a chronic case, maybe in years when the patient is taking, then it will develop. So what are the drugs? Vishnu, Dipanjali, both of you are correct. So what are the two important drugs? Please remember the liver OK drugs. You can remember it with this mnemonic: liver OK drugs, lorazepam and oxazepam. Both have been asked in the exams. So please remember both of these drugs. Princess Veronica, very good. Yes. Is it clear to everyone? Also, what else we can add, beta? Please remember, along with benzodiazepine, what else can you add? What else can you add? Anybody? What else can you add in this? You can also add thiamine. Please remember thiamine again, because many of these patients may also have deficiency of thiamine. Now, so let's come back again. Please remember, beta, although there is hallucination, there is no role of haloperidol. So the treatment is diazepam plus thiamine. Is it clear to everyone? Is it clear to everyone? Very good. Yes, Rushabh, Ariwa, Dr. Respect, Ashan Khan, Arsalan, yes, Pranoy, Afsar, very good, Vikas. Now, in the maintenance, do remember, in the maintenance we have anti-craving agents such as acamprosate, anti-craving agents and naltrexone. Please remember acamprosate and naltrexone. Acamprosate is NMDA antagonist, and naltrexone is mu antagonist. And we also have one more drug we can use. So these are anti-craving agents. We can also use disulfiram. Please remember at least the mechanism of action. It is a aldehyde dehydrogenase inhibitor. Please remember at least these mechanism of action of these drugs. Is it clear to everyone? Yeah, you can give multivitamin. Yes, you can give that. But yes, thiamine in high doses is required. Is it clear to everyone? Very good. Let's come to the next question. Again, a very important topic. A 40-year-old male presents with symptoms of tachycardia, tachypnea, hypothermia, scratch marks. Associated, this substance is also associated with nasal septal defect and blackening of the tongue. Which of the following substance is the patient consuming? Yes, Sanjay, we can give, but thiamine high dose is required in such patients. Very good. This is again, I've tried to give you a lot of information, and be prepared. Again, they may give you a ENT like question. Patient has nasal, septal perforation, and there is blackening of tongue. Which substance? So they may give you images. So they may give question related with ENT as well. Such integrations may be asked. So please remember, it is cocaine. Cocaine is a stimulant. Very good. Why scratch marks? Can anybody tell me why the scratch marks? Very good. Yes, Dr. Benedict. Yes, Mithu. Correct. Mithu Kumar. Yes, Crazy Doctor. All of you are correct. Very good. Dipanjali, Art Time, Vikas Raj, Dr. N. Kumar, Ruxana. All of you are correct. Very good. So it is, yes, correct. It is cocaine. So just few points. It is a stimulant. Cocaine is a stimulant. So it can cause tachycardia, hypertension. This question was also asked. Which of the following is not seen with cocaine? Tachycardia, hypertension, cardiac arrhythmias and bradycardia. So bradycardia was the answer. It's a stimulant. Cardiac arrhythmias can occur, even seizures can occur. Cocaine bugs, these are tactile hallucination. This question has been asked recently also. Tactile hallucination, also known as formication. Formication, this question was asked. Again, please remember. So this can be seen. So scratch mark, patient is scratching because he is experiencing tactile hallucination. Very good. So these findings also can be seen. Jet black pigmentation of the tongue, then nasal septal perforation can also be seen. Very good. So many questions have been asked from cocaine, so please be prepared. What are speedballs? Anybody? Can anybody tell me what are speedballs? These are when a person combines cocaine with opioids such as heroin. Okay. So again, many important previously asked questions have come from this topic. Very good, Dipanjali, Riya, very good. Correct. Very good. Let's come to this question now. 19-year-old, this is I think again a straightforward question. Please be prepared with such questions. 19-year-old male brought to the emergency with complaints of abdominal cramp, diarrhea, rhinorrhea, sweating, lacrimation. So they have given you some of the important symptoms. So now can you tell me what is the answer? Examination, pupil is dilated, that they have also said. Substance use history is there and the person has not taken since 3 days. So the patient has come in withdrawal state. What is the withdrawal? Which is that withdrawal? Very good. It is opioid or heroin withdrawal. Very good. The right answer is this. All of you are correct. Yes, AD, Yashwant, Kishore, Afshar, Mayank, Dr. Benedict, Mithu, Dr. Disrespect, Yashwant, Akshan Khan. Very good. Very good. Creative Divs. Yes, correct. So it is this. Yes, Dipanjali, Ayruva. Very good. So opioid withdrawals, again more important recently asked question was on opioid is intoxication. So what are the withdrawal symptoms? Again, just I have clubbed these symptoms together so that it becomes easy for you to remember. So these are flu-like symptoms. So first you can remember is there is pain. So there is pain such as muscle pain, bone aches, abdominal cramps, patient complains of pain. Second is patient complains of leaking of the body outlets. So you can remember it like this, such as diarrhea, lacrimation, rhinorrhea, sweating. So patient is complaining of leaking of the body outlets. Piloerection or goose flesh may occur, so the body hairs may become erect. Excessive yawning may occur, and if you look into the eyes of the patient, what will you find, beta? You will find pupillary dilatation or mydriasis. Okay, okay, yeah. Yashwant, no, it does not have. Usually we say hallucinogens. Hallucinogens don't have withdrawals. Okay, so usually say we hallucinogens. LSD is an hallucinogen. It does not have withdrawal. Okay, so is it clear to everyone? More importantly, the recently asked questions have been on opioid. Even recently asked question was also in opioid intoxication. What is the clinical triad of intoxication? Again, remember respiratory depression, pinpoint pupil, and coma. So the doctor has given morphine to a patient and the patient has developed respiratory depression. So what is it suggesting? That maybe there is overdose. So how will you treat? The question has been asked on what is the drug of choice. Okay, yes, very good, Dr. Benedict. Yes, flashback, bad trips, yes, with LSD. Very good. So what is the drug of choice of opioid intoxication? This has been asked numerous times. IV naloxone, which is a short acting mu opioid antagonist. Please remember this. Recently also many questions have come from this topic. Is it clear to everyone? Now next question. A 6-year-old male presents to the clinic by her mother with complaints of poor speech development. On examination, the child has difficulty concentrating and communicating and has poor speech development. Mother also reports that he has no friends and spends most of the time looking at his hands. Which of the following is the most likely diagnosis? Please try to see, beta. There is poor communication. There is poor communication in the patient, and the person is also repeating certain behaviors such as looking at the hands. So what is the diagnosis? Please remember the diagnosis is autism. Very good. All of you are correct. Yes, very good. All of you have autism. So in autism spectrum, this is a new term in DSM-5 and ICD-11. So two core symptoms occur, that is deficit in social communication and repetitive patterns of behavior. What was the third symptom which is now, although this third symptom is seen in the patient, but what is the third symptom which has now been removed from the core criteria? So can anybody tell me? Very good. Yes, good doctor, very good. He has been, in fact, Dr. Sean Murphy has been diagnosed with yes, autism spectrum disorder. Very good. So they have given the, in fact, the diagnosis. So language impairment is now no longer No longer. Very good. Yes, Rishabh. Amenorrhea, Dipanjali, is for which disorder? It is more, we'll talk about, that was anorexia. Language impairment, it is no longer a core criteria. There is 2 core criterias. It is now no longer a core criteria. So we have classical autism, Rett syndrome, Heller syndrome, Asperger syndrome under autism spectrum disorder. Very good, Rishabh. Dr. Bennett, yes. Is it clear to everyone? One important point I want you to remember is, again, it's a very important topic. Please revise Rett syndrome, very, very important. So Rett syndrome will have symptoms of, social communication deficit and repetitive behavior, but some important characteristic. Okay, right. Okay, right. Now, few important characteristic. One is, in the first 5 months, the development of the child is absolutely normal. It's absolutely normal. The problem starts from 6 months to 2 years. Again, stereotypic movements may occur in the hand, such as hand wringing movements. Microcephaly, again, please remember, please listen to what I am saying. If you are asked, microcephaly seen at birth in Rett syndrome, no, it is false. It is seen after 5 months. Okay, and suppose they say macrocephaly seen at 6 months, again, it is not macro, it is micro. So sometimes they may just play with the words. Please remember this. Loss of speech, muscle coordination may be abnormal. There may be even ataxia. Okay, seizures may also be seen. Okay, seizures may also be seen in the patients. Okay, yes, it is more common in females than males. Very good. This is a very important point which has been asked in NEET PG 2022. Okay, there is a known genetic risk factor, MECP2 gene on chromosome XP28. So there is a known genetic risk factor also with Rett syndrome. So this was about Rett syndrome. Also, I'm sure you would know, this question was asked in the last INI-CET exam also, that there is a new drug which has been approved for. Okay, very good. If you're planning, Dr. Benedict, very good. So yes, very good, Vikas. Yes, Aman, very good. So what is that new drug? Trofinetide. Please remember this new drug for Rett syndrome, approved for children more than 2 years of age. Okay, the brand name is Debut. You can remember like Debut. Trofinetide, it's a tripeptide. Very good, Vikas, very good. Glycine, proline and glutamic acid. It's an analog of amino terminal tripeptide of IGF-1 insulin, like growth factor 1. Okay, so it has anti-inflammatory property. Also, it causes synapse maturation. So these are some of the effect of this drug. Very, very important, has been asked. Okay, yeah, great. So I hope it is clear to everyone. This is again a very important point. Is it clear to everyone? So what I'm trying to discuss is, along with clinical questions, some of the important high yielding points for the upcoming exams. Now next question, again, this is again very important. Such questions have been asked on therapy again and again. A male patient comes with history of marital conflicts and complains of early ejaculation. So what is the diagnosis? Premature ejaculation. The question is, which of the following non-pharmacological method may be useful in this condition? So what is the right answer here? Very good. It is squeeze technique. So one is squeeze technique used for premature ejaculation. Very good. Another is stop start technique. Stop start technique. Very good. So this is again a very important point. Please remember this. Okay. So this is again a very, very important point. I hope it is clear to everyone. Very good. Great. So such questions have been asked. Now what I am trying to ask you again, it's a very important clinical scenario. One of the clinical scenario was asked in AIIMS exams once. So this is again a very important slide for your upcoming exams. Suppose you have a patient of anorexia nervosa. Suppose you have a patient of anorexia nervosa. We know anorexia nervosa is more common in females than males. Person has reduced weight. There is, again, fear of gaining weight is there, and there is disturbed body image. These are the 3 important symptoms of anorexia nervosa. The question is very good. Yes. Now listen to this question, again a very interesting clinical scenario. One of them was asked, one may be asked in the future exams. So you have, again, in such patients, usually mortality is high. Many times patient does not accept treatment. Many times we have to admit the patient. So again, we may have to admit the patient. So some of the important indications, such as there is complications. Patient was not eating, so complications such as starvation, electrolyte imbalance, dehydration. So these are complications. Also, if the weight by height decreases by 20%, this is another indication of admission. So we may have to admit. So you have admitted a patient and you are feeding the patient, you are giving adequate. So one situation is, let us say, so two important situations I want you to remember. One was asked, suppose they say that you give adequate calories to the patient but there is no weight gain. So for 1 week you have given adequate calorie, usually start with 1500 to 1800 kilocalorie per day and then we gradually increase. They say there is no weight gain. So what is the next step you will do? Will you increase the calorie? Will you give any drug? Or will you do something else? What is the first step you may do in such patients? Please remember, anorexia nervosa has two subtypes. One is restrictive type, in which patient eats less, and other is binge eating purging type. Okay, here also binge eating purging may occur. So what will you do? Very good Mayank, very good Rushabh, Rahul Katari, very good. So maybe this patient belongs to this binge eating purging type and patient after every meal goes to the washroom and purges out. So very good, observe, very good, observe the patient 2 hours after each meal. Okay, very good, correct, very good. This was AIMS question. Now suppose you, second scenario is you are feeding the patient, okay, you are giving calories and the patient comes to you with the decrease in the, so there is decrease in the phosphate, decrease potassium, decrease magnesium. Patient also develops thiamine deficiency and patient also develops cardiac arrhythmias. Patient also develops cardiac arrhythmia. This is again, please remember, such integrated questions may be asked in your exam. So the clinical scenario here is that a patient after feeding has developed these symptoms. So what now would you suspect? Anybody? Can anybody tell me what would you suspect in this scenario? What will you suspect in this scenario? Anybody? So what would be the answer? This is again a very important question, you may have read even in surgery. Okay, even in surgery. So what this is happening, maybe you are feeding the patient, you know, again you are feeding excessively. So you are feeding excessively, because of which, very good, this is, yes Afsar, very good, Vikas, Rushabh, Benedict, very good, this is refeeding syndrome, very good. So please remember such question, this is refeeding syndrome, very good, refeeding syndrome. Okay, very good. So remember this, such questions may also come. So this is a very important clinical scenario which we have discussed. Next question, let's come to the next question. Very good, yes Dr. Dispect, yes Mithu, very good. Now this is again a very important topic, lithium. Whenever you are going to the exam, please revise lithium. Many questions have been asked on lithium. So let's discuss this. A 40-year-old male presents with symptoms of cheerfulness, symptoms of increased energy, overspending, racing thoughts, decreased sleep for 10 days. And so what is the diagnosis? Diagnosis seems to be an episode of mania. So patient comes to you in mania. History of similar to episodes in the past. So previously also there have been manic episodes and patient was started on lithium. Now, so this is a case of bipolar disorder, come to you with manic episode. They say the patient is started on lithium. Patient developed fever and vomiting from an outbreak of gastroenteritis at a marriage function he visited 1 day back. So he goes to a wedding and he develops, you know, vomiting and fever. But unlike other people in the function, so along with these symptoms, the patient also has developed tremors, ataxia, nystagmus. Are you able to understand the clinical scenario? So beta, what has happened is the patient has developed certain symptoms on lithium. Very good. So what will you do? So what I am trying to say, please remember this. What are they trying to tell you? So along with fever, vomiting, the patient has also developed tremors, ataxia, nystagmus. What are you going to suspect? What are we going to suspect in this case? So please remember our body. So this is a very important concept which I am telling you related to lithium toxicity. Lithium toxicity. It is suggesting, these symptoms are suggesting that there is lithium toxicity, that our body treats lithium, similar to sodium. So suppose, so in dehydration what happens to beta sodium? The body reabsorbs sodium. So the body will also reabsorb lithium. So if a person is dehydrated with having lithium, the person may develop lithium toxicity. Similarly, patient has developed vomiting, diarrhea. Again, there may be reabsorption of sodium in the body, and there may also be reabsorption of lithium. Lithium toxicity can occur. These are signs of lithium toxicity. What are you going to check? Lithium levels. Of course, you will check all these others also. Yes. So this is again very, very important. So lithium, very important drug. You can remember one name associated with lithium. A lot of work has been done by John F. J. Cade. Therapeutic range asked in recently INI-CET exam 0.5 to 1.5. Acute mania, it is 1 to 1.5 milliequivalent per liter. Maintenance 0.6 to 1.2. Toxicity occurs, it is when it is more than 1.5. Very good. So just few points about toxicity. Again, you may not remember all the values, but please at least remember the signs and symptoms of lithium toxicity. Like in mild to moderate, there may be vomiting, abdominal pain, ataxia, nystagmus, muscle weakness can occur. In moderate to severe, there may be hyperactive, deep tendon reflexes, convulsions, coma, stupor. And if it is severe, it may have generalized. So in severe, there may be generalized convulsions, oliguria, renal failure and death. So some of the signs of lithium toxicity were seen in the case. Yes, it has a narrow therapeutic index. Very good. So again, what is the management? Yes, we'll stop lithium, correct hydration, removal of any unabsorbed lithium from the GI tract. So we may use polyethylene glycol, sodium polystyrene sulfonate. Do activated charcoal have a role? No, it does not have a role. And in severe cases, hemodialysis may be required. So there was once a question that hemodialysis is not required. It's a false statement. In severe cases, you may require hemodialysis. Is it clear to everyone? This is about lithium toxicity, very important topic. Many times it has been asked in your exams. Is it clear to everyone? So these were the important MCQs. Again, we have pro plan for all of you. Again, India's only clinical QBank. Again, some of the questions which I have discussed, in this, discussion has been taken directly from the QBank. So again, a very important, tool for your exam preparation. So you may have, it has a lot of treasures also, clinical based questions as well. So this was about today's session. Again, for all the students who will be giving the FMG exam, just in coming 2 weeks, all the very best. Stay calm, you'll do well, don't worry, everything will be good. Just keep on revising. So again, as I say, keep smiling, keep moving forward, and all the very best. There may be, so those for future examinees for NEET PG, again, keep on studying, keep on revising, very, very important, and keep on solving MCQs, very, very important. So thank you everyone. Again, thank you. Great. Thank you everyone. Bye-bye.